evening, friends. So I will be talking today on biomaterials and tissue engineering. This is a very new concept. We are seeing as a sports doctor, I am seeing a lot number of athletes, and also there's a nowadays trend of fitness in especially major cities like Delhi and Mumbai. So people at quite a younger age are getting injured in various joints like knee joint, elbow joint, shoulder joint, and at a younger age we are seeing damage to cartilage. So this cartilage is basically a structure which is kind of like a tubing in a tire. So it's like if it is a car vehicle or a cycle or a motorcycle, there is a rim and there is a tire. So the main action of the wheel is on the tire. So cartilage is something like that. It is a lining of the cartilage, lining of the joint, which basically on which the joint runs. And unfortunately or fortunately, our cartilage is very special. It's once it is damaged, it never comes back, and this is called as highland cartilage. So we at earlier time we used to see damage to cartilage and osteoarthritis happening in elderly people like plus 50 people, plus 55 people, or plus 60 age group. But as I said, because of the increase in sporting activities, increase in fitness activities, also increase in weights. So people of all people are getting more obese also. So we are seeing a lot of people coming to us with cartilage damage at an early age. So I will be now talking on something as called as tissue engineering, which is a novel technology which is worldwide being experimented, and now we are moving on from joint replacement to joint preservation. So what is biomaterial? Biomaterial is a science of engineering. It's a science, a branch of engineering basically, which involves making those devices, making those structures which are helpful in kind of restoring joint function, restoring biomechanics, restoring injured parts of the body. So biomaterials can be hard walls, can be prosthetic joints, can be cartilage structures, cartilage, new cartilage, can be dental implants, can be blood vessel grafts. So these are all comes in biomaterials. So they are basically engineered devices which are biocompatible. So there is a concept of regenerate, repair, and replace. So regeneration means like growing a new limb. So this is again more in experimental states. Repair is when we repair any structure at a molecular level, like a DNA level, and replace is when we use a biological substrate which is produced in the laboratory as a substitute for broken, damaged cartilage. I'll be focusing in this talk mainly on the replacement part, but which is this is not a replacement, it's a joint replacement. This is more of a joint preservation, where the damaged cartilage is being replaced by cartilage. So osteochondral defects is a term used for damaged cartilage when the young patient or young person under 40 to 45 comes to us and we do an MRI or any arthroscopy and we find that cartilage is damaged. So cartilage का जो defect होता है cartilage, that defected area of cartilage is called as osteochondral defect. There are various techniques nowadays we are using to fulfill that cartilage. One is we perforate that area, which is called as micro fracture or prediced perforation. Sometimes we take cartilage graft from a area of the knee joint which is non-weight bearing, like a front of the femur, and put it into that area with the damaged cartilage. This is called as mosaic plastic. But there are a lot of challenges in this treatments. The challenges are that the cartilage which is formed is a fibrocartilage. As I said, the natural cartilage in our joints is hyaline cartilage, and there is still now with a lot of research is going on, but still now we haven't devised any method which grows back the normal hyaline cartilage. So the fibrocartilage which is formed, it has issues with durability, it has issues with sustainability, it has issues with donor site morbidity, but still we make every possible attempt that the cartilage formed by the technique is as close to nature as possible and does its job. Three types of basically parameters which we assess in biomedical engineering. One is the cells which we use are the pluripotent cells which differentiate into the cartilage. This is the productive. So this is called as productive aspect. Second is how to put those cells into that area of the defect so that the cells kind of regrow and multiply to form cartilage. This is called something called as scaffold, and this scaffold is called as being conducive or conductive. And the third is adding stimulants to that area, adding stimulants to the cartilage, to that scaffold area, and adding growth factors cytokines, which is called as inductive. So productive, conductive, and inductive. So conceptually, tissue engineering is contains the following mixtures. One is biological components. One is non-biological component. As I said, the biological component is a cell which will actually form the cartilage, which is the productive part. The non-biological component is a scaffold in which the cells will have to be placed to be put into the defect. This is called as a scaffold or the conductive part. And the biological component, bioactive factors, are those factors which will produce cytokines and certain growth factors to stimulate cartilage regeneration. That is the inductive part. So broadly, there are three therapeutic principles of cartilage tissue engineering. One is implantation of freshly isolated or cultured cells. So what we do is that we take the cell from the joint. That is the first surgery. We put it in a petri dish and package it and send it to the lab. The labs of these are based in either Mumbai and Pune and Western countries like Germany and France. So these labs grow the cells, multiply them, and over a period of 6 weeks or so, the cells are produced. And these cells or regenerative cells are then taken back and reimplanted into the affected area of the joint where the damage of the cartilage is there. So first step is isolation of the cells and culturing them. Second step is implantation of the cells in the defected area for which we use a scaffold. And the third is in situ regeneration. That is when we transplant from one area of the cartilage to another area, is called in situ regeneration. So there are three types of cell sources. One is the primary and chondrocytic cell lines, which is the best cell line. So in this, the cells are dedifferentiated and they lose the phenotype and then they form the cartilage. Second is the adult mesenchymal stem cells, which are obtained from the bone marrow. And third is the embryonic stem cells. So you might have heard that nowadays many IVF centers and many centers are offering embryo cells to be frozen. The whole idea is that in future, when these technologies grow, so the embryo cells can be used for that purpose, because the embryo is the stem cell, and that stem cell can be used to multiply into any form of cell. So this is the concept of storing the embryo and storing the fetal cells. So biomaterials in cartilage depend on three types: scaffolds, hybrid constructs, and bioadhesives. So as I said, the whole idea of scaffold is to basically it's like a what do you call it, a structure where you put the cells and then place it inside the defect, and it will provide us like a scaffold or a platform for the cells to multiply. So scaffolds can be synthetic polymers, can be natural polymers. Design criteria is of scaffold. They are biofunctional. We check whether they are biofunctional. That means they are doing their job. Biomimetic. That means they are compatible with the body and the geometry. And biocompatible, as I said, they don't mount an immune reaction. Then another aspect of scaffold is durability, and the fifth aspect is bioconductivity. Now we'll come to a technique called as autologous chondrocyte implantation. So this is the most modern technique which has gone through many stages of evolution. This technique, as I was talking in the beginning, the whole idea is that in younger patients who are coming with cartilage damage, what do we do? So we have an option of use of culturing the chondrocytes and then putting them back into the cartilage defect. It is called as autologous chondrocyte implantation (ACI). So in the first generation ACI, we used to use fibrin glue. So we used to harvest the stems, harvest the cartilage cells, go into culture media. The harvested cells are then put back into the defect and sealed with a fibrin glue, but with a periosteal flap. But there were a lot of failures. So the second generation ACI came. In the second generation ACI, we use a bilayer collagen membrane, which basically kind of removed the need of periosteal flap and the donor side mobility. But again, there were some issues with that also. And then, so we are now coming to the concept of third generation ACI, which is all in one tissue engineering approach. In this, what we do is that the cultured chondrocytes are combined with a three-dimensional biocompatible scaffold, and then this whole composite mixture of scaffold and chondrocytes is then placed into the defect. So there are various types of third generation ACI. They come with various names. A company from UK produces it in the form of Condron. There is a company from Italy which produces Hydrograph C. There is a company from Germany which gives Bioseed C. Then Cartipatch is a company from France. It comes with a trade name of Cartipatch. And then MACI is produced by Genzyme, which is based in United States of America. So third generation ACI is the current standard of care for tissue engineering and for cartilage repair. In our practice, we are more commonly using Macy and Condron from UK. The whole thing is that we put the cartilage, take out the cartilage cells, regrow them in a lab, and then put them back into the cartilage defect. The early studies are promising, and this is the way forward. So there are a lot of studies going on, and still we are evolving and learning. But yes, this is something which is very helpful for sports persons, very helpful for people in early age group who are having damaged cartilage. And I think this is the way forward from joint replacement to joint preservation. Thank you.